right, guys, this is oral surgery guy. Sorry, can't show his face. Caught him on the way home. So he's going to help us go over this lit real fast. So can you tell us a little bit about tell us a little bit about it, and like what are the take-home messages from this article? Because like there's a lot in there, and I'm just trying to like whittle it down to like the most important things.
Yeah, for sure, man. I think if I had to make this really concise, the take-home message is that the more cancellous bone, so our bones have a cortical shell around it. That's the thicker, the denser bone. And within that, you have the cancellous bone. So what the study was going out to find was what determines how successful an implant will be. And what they were looking at is the amount of cancellous versus cortical bone. And what they essentially found is, and it logically makes sense, the more cancellous bone, which is the less dense bone, kind of the spongier bone that we have, the more of that you have, the less likely that your implant is to, succeed, because you have less of a sturdy foundation to put your implant into. And where this kind of draws in, it pulls in osteoporosis, because in osteoporosis, essentially as you get older, your bones get less dense. And the way that they measure your density is something called bone mineral density. And you have to go for a bone scan to officially get it, to see how dense your bones are. But essentially you can look at a scan as well and see, hey, like when you're a younger person, you're going to see a lot more opaque bone, denser bone. And even in the cancellous bone, there's more what we call trabeculations. So more surface area. And as you get older, first the cancellous bone goes, it gets weaker, and then eventually your cortical bone also gets weaker. So essentially what it's saying is, as you get older, the reason why implants are less successful versus a young person is because you do have less density, not in both cortical and cancellous, but specifically when you look at an x-ray or a scan, you see more cancellous space as you get older.
Should we basically be more worried about osteoporosis, or should we just look at the x-ray and decide?
So I think, as with everything, when we do history and physicals, you got to look at everything together, So I think it's important. Someone comes into your office and says, hey, I have osteoporosis, but you look at their scan and it looks good, So in that case, you'd be like, okay, I think the implant would have a good chance of succeeding. Or some guy comes in, no, I don't have osteoporosis. My doctor checks me every year. But you look at the scan and he has like tapered thin cortical bone and a bunch of cancellous bone. And you got to think, all right, this guy says he goes to the doctor all the time, but even though he says he doesn't have osteoporosis, he might have osteoporosis. Maybe he has a doctor who's not really with it, or maybe he doesn't really go to the doctor, or he takes a medication that you don't know about that has side effects. So I think you have to take everything together as a big picture and use your clinical judgment as a physician or as a clinician to provide what's best for the patient,
So then osteoporosis and like having more cancellous space, that's essentially just like another risk factor that we use to screen our patients. So like just like smoking, just like diabetes, we're going to ask them about osteoporosis, and we're going to look at the slice of the cone beam to see how much cancellous space there is, right?
Exactly.
I saw something here that said, okay, each millimeter increase in cancellous space was associated with 2.3 times increase of implant failure. That's a lot, right?
Yeah. I mean, it's a little, where we're working with those spaces, it's down to the millimeter, our implants are a few millimeters in diameter and, 8 to 15 millimeters long, so every millimeter matters. So when I read that, I wasn't necessarily surprised that, every 2 millimeter increase results in an exponential increase in failures.
So someone's going to ask me, guaranteed, they're going to say, okay, so how much is okay? Like, what's the limit? So like, it looks like from these numbers, what, like they could, like an easy reference is like 6 millimeters, plate to plate. That's like, if you have more than 6 millimeters, then you see a bigger drop.
Yeah, I wouldn't take those as hard fast numbers. I think the point is that as it increase, I don't think there's a hard fast number. Say if it's over 6, it's going to fail. That's not necessarily true, because it also depends on the diameter of the implant you're using. You're using a 3.5, or using a 4.3 or 4.8. Those things all play a part. They weren't explicit in this article as to what size these implants were, and for all we know, it was done by a single provider, he could have used a handful of 3.5s, a handful of 4.3s, a handful of 4.8s. So it's hard to have a hard fast number, but I think what's important is that, you know, when you put this implant in, you know, when you dunk this implant in, you want to get into a spot where it engages as much cortical bone as you can.
Right.
Because like you said, if you're just sinking into a bunch of spongy, weak bone, logically, it's not going to hold as well.
Mm-hmm. So try to engage some cortical bone when you can, right?
Exactly.
Yeah.
But I think what's also important with these patients is, and I don't know if, at least we see it a lot, and I'm seeing it more and more, you know, a lot of doctors are going ahead and just prescribing their patients with bisphosphonates or you know, denosumab, also known as Prolia. You know, these are all drugs to help you increase your bone mineral density. Mm-hmm. And, you know, their point is that they want to get the bone stronger. And they achieve that by giving their patients these drugs. But a lot of times, these patients are completely unaware that if they get a tooth pulled or any sort of trauma or get an implant placed, you know, you risk getting osteonecrosis of the jaw. And this happens a lot more often than we would like, and we're starting to see it happen more and more as time goes on as well.
Right. And like by and large, for people that are watching this, the main concern is not going to be medication related necrosis of the jaw, right? Because if they're taking IV bisphosphonates, they're basically going to refer them out to you, right? Yeah, you probably get a lot of those referrals, I guess.
We do, but I think what is even more, you know, what happens more often is that these patients don't know. You know, it's easy for a patient, you know, it's easy for us to go, hey, you have osteoporosis, you must take some sort of drug for it. You know, a lot of times you ask a patient, what medications are you on? I'm on nothing. Yeah, you ask a patient, you know, what medical history you have? I have nothing. And then you probe a little more and they're like, oh, I have diabetes. Actually, I have hypothyroidism. Like, these are things that unless you really push into it, they're going to deny it, because, you know, I feel if they feel good, then they're going to assume that everything's, you know, status quo and nothing's wrong.
I got one more question for you, man.
Yeah.
So I don't know, does this article differentiate between the quality of the cancellous bone? Like, for example, this one looks different than this one, right? This is just like a dark void with nothing inside, whereas this one has a more dense cancellous bone.
So I think that goes back to what I was saying earlier too. You know, there's early and late stage osteoporosis, and the way that it works is the overall bone mineral density will decrease, but it starts with your cancellous bone and those trabeculations. The trabeculations show up as those opacities, you know. So the more of those you have, the more dense your bone is, the stronger technically your bone is. But in someone with late stage osteoporosis, you'll see a bigger void because of less trabeculations, less surface area, and less weaker bone.
Gotcha. Okay, so if this person right here had osteoporosis, it's not as advanced as somebody who's with this presentation.
I would say so, yeah. Obviously, the contrast is a little bit off and different. You know, that might play into what we're seeing here. But if I had to say, I would say this one that we're looking at right now is definitely on the more severe side of osteoporosis than the one we just saw a minute ago.
Okay, awesome. So I'm just going to list out a couple of the takeaways that kind of jump out to me. So first, you got to screen your patients for osteoporosis. Second, in conjunction with that, you want to look at a slice of a cone beam when possible and evaluate that cancellous space. And the wider that space, the more likely that you might have trouble with that implant. So in order to, counteract that, you try to engage cortical bone when you can.
Exactly. Yeah, I think so. And I think if they're on bisphosphonates, you know, if they're on IV bisphosphonates, it's a more severe, you know, the risk of getting medication related osteonecrosis of the jaw is higher than if you're taking an oral form of it. And I think the takeaway is, I guess the rule of thumb is that if they're on these medications, if it's less than 4 years, the article, like the Amos, sorry, this is, I have to cut this, I have to edit this part, sorry.
That's all right, no worries.
So for patients who've taken the oral form for less than 4 years and have no other clinical risk factors, they said it's, you know, there isn't a necessity to necessarily make them stop, but you should definitely advise them that, hey, because you're on this drug, you could have a higher risk of having osteonecrosis. But for patients who have taken these oral medications, these oral bisphosphonates for less than 4 years and have other anti-angiogenic or corticosteroid medications that they're taking, or if they've taken it for over 4 years, the rule of thumb is you want to have them off it for 2 months at least, a drug holiday for 2 months, and then they can resume it once adequate healing has taken place. So, you know, 2 months off before the implant and then 2 months off after is probably a safe bet. But still, these patients, you want to counsel them just, you know, just at baseline, you're on these drugs. And even if we do this 2 months before break and 2 months after break, you're still subject to a higher risk than the regular Joe on the street, you know?
Awesome. Awesome. Thanks so much, dude. I really appreciate that.